viewers and participants who have joined from various parts of India and abroad. Welcome to this live webinar. I am Sumit Kumar Madan from Zydus Life Sciences Limited, and on behalf of Zydus, I welcome our guest speaker, Dr. Riya Balikar, Chief Guest Dr. Dilip Kohukar, all discussants and participants to this virtual symposium on Hodgkin's lymphoma, optimizing treatment in the era of targeted therapy. Before we commence the proceedings, I would like to welcome and introduce the host and convener for this webinar under the aegis of Mumbai Hematology Group, Dr. Amit Khurana. Dr. Amit is a very passionate and dynamic hematologist and bone marrow transplant physician from Surat in Gujarat. I request Dr. Amit Khurana to navigate this program further. Sir, over to you.
Thank you, Mr. Sumit Madan. Well, very good morning to all of you, and good afternoon and good evening to all others who are joining from rest part of the world. Today, our guest speaker for the day is Dr. Riya Balikar from Nagpur, and she's going to lecture us on Hodgkin's lymphoma, optimizing treatment in the era of targeted therapy. This webinar is brought to you by Mumbai Hematology Group, supported by Zydus, dedicated to life, and managed by Perfect Square. I thank Mr. Ashish Kumar, Mr. Sumit Madan, and the team Zydus, Mr. Yash, Mr. Kalpesh, and the team Perfect Square, Executive Committee of Mumbai Hematology Group, our chief guest for the day, Dr. Dilip Kohukar from Nagpur, our guest speaker for the day, Dr. Riya Balikar from Nagpur, all our discussants who are themselves very eminent hematologists and hemato-oncologists, and you participants for spending the Sunday morning, afternoon, and evening. Let me give you the flavor of next weekend activities. Next Saturday, that is 16th of December 2023 from 7 p.m. onwards, we have a webinar on MDS and updated approach to diagnosis and treatment by our guest speaker, Dr. Aditi Shastri from Bronx, New York. And the following day, that is on Sunday, 17th December 2023 from 11:30 a.m. IST onwards, we have a webinar on systemic mastocytosis by our own guest speaker, Sergeant Commander V.A. Arun from INHS Aswini Kolaba, Mumbai. Now it's the time to introduce our guest speakers for the day. Now it's the time to introduce our discussants for the day. And we have a galaxy of them here displayed in alphabetical order. To start with, we have Dr. Akanksha Garg from Zydus Hospitals, Ahmedabad. Dr. Amrita Chakrabarti from Max Hospital, Shalimar Bagh, Delhi. Dr. Anshul Gupta from Medanta, Lucknow. Dr. Aryan Jain from PGI, Chandigarh. Dr. Ashish Dixit from Manipal Hospital, Bengaluru. Dr. Ashraful Haq Chaudhary from Dhaka Medical College Hospital, Dhaka, Bangladesh. Dr. Gaurav Dixit from Artemis Hospital, Gurgaon. Dr. Gaurav Prakash from PGI, Chandigarh. Dr. Gopinathan M from MGM Healthcare, Chennai. Dr. Hari Menon from St. John's Medical College Hospital, Bengaluru. Dr. Neil Thanda from Myanmar. Dr. Humaira Nazneen from Dhaka Medical College Hospital, Dhaka, Bangladesh. Dr. Javed Rasul from Sher-I Kashmir Institute of Medical Sciences, KIMS, Srinagar, Jammu and Kashmir. Dr. Kunal Goyal from ACTREC, Mumbai. Colonel Dr. Kundan Mishra from Command Hospital, Lucknow. Dr. Nitin Gupta from Sir Gangaram Hospital, Delhi. Dr. Pujita Bai Reddy from Banjara Hills, Hyderabad. Dr. Prashant Mehta from Amrita Institute of Medical Sciences, Faridabad. Dr. Rajan Yadav from GCRI and BJMC, Ahmedabad. Dr. Tulika Sheth from AIMS, Delhi. Now it's the time to introduce our special guest for the day. We have with us our chief guest, Dr. Dilip Kohukar. Dr. Dilip Kohukar is consultant hematologist at Lokmat Bhavan, Nagpur. He has passed his MD Medicine from Government Medical College, Nagpur in the year 1982. He did his residency in hemato-oncology at Tata Memorial Hospital, Mumbai for the period of 2 years. He also became the resident in hematopathology at Tata Memorial Hospital, Mumbai for the period of 1 year. He has a research scholarship at Karolinska Institute, Stockholm, Sweden, fellowship in hematology at Ealing Hospital, Southall, UK, practicing hematology in Nagpur for over 3 decades from the year 1989 till date. He is a founder secretary of Central India Hematology Society in the year 1992, chairman Hematology Masterclass in the year 2018, and he has got numerous publications in peer-reviewed national and international journals. It's my privilege to welcome him to inaugurate our webinar and give some words of wisdom. Over to you, Dr. Dilip Kohukar.
Thanks, Dr. Amit, for my introduction. And thanks a lot, Himit for the invitation. It was indeed a pleasant surprise and an honor to get invitation to be the chief guest today. As per Dr. Agarwal's suggestion, my short address today will be for the young generation, the budding hematologists who selected this branch. This includes some tips to become an experienced hematologist in a straightforward way or in a practical term. That means a hands-on training. This is very important. After being in practice for over 35 years, I have realized a few points. Sorry, there was a disturbance from the call. I have realized a few points which the new generation will find useful and perhaps interesting. The first point, when I entered this field in the beginning of my career, was that hematology is a different science. It differs from cardiology, neurology, and other clinical branches of medicine. Basically, it's a hybrid science with a combination of medicine and pathology, or better, hematopathology, to be specific. When you enter, sorry for there was another call. It's a hybrid science with a combination of medicine and pathology, or better, hematopathology, to be specific. When you enter in this field, apart from good foundation in medicine, you will need to be well conversant with the common medical emergencies as well, which can range from management of anaphylaxis, vasovagal attacks, cardiac arrhythmias, convulsions, and so on. It will be even more rewarding for the young hematologists if you have completed a residency in critical care unit, because while managing hematological cases, you are going to face all these events. There is no scope for complacency, as some of these can be fatal, requiring immediate reflex action. And then comes the next part. Once you have seen the patient, you have to investigate the case. I personally feel that the person who has examined the case, who knows the history and clinical findings of the patient, is in a better shape or position to interpret pathology. From this point onwards, your lab expertise comes into the picture. You need to develop fluency in the interpretation of peripheral blood and bone marrow slides. Coming from a background of medicine, I did MD in medicine. It looked fairly difficult for me initially. I had to spend nearly 2 years in hematopathology labs, which helped me later to run the setup independently. At the same time, you have to check your technicians to see if they have adequate experience and competency. This is important because in many cases, hematological diagnosis remains unchanged for the lifetime, and somebody somewhere is almost always going to cross-check it. So, to get trained in hematology appears a little bit complicated. 35, 40 years back, there was no formal degree like DM hematology and no streamlined training schedule. So we had to move from one place to another. I myself worked in Tata Memorial Center, Mumbai, then abroad in Karolinska Institute and Ealing Hospital. Fortunately, these places had huge workload and were also the best places to learn hematology. That made my training easy. And what about future? What will you see after say 30 years? The young generation has to get ready for the year 2053. The future belongs to basic sciences. For the next 30, 35 years, you will be witnessing exciting discoveries. As it is today, RIA is also discussing about targeted treatment for Hodgkin's lymphoma. And slowly we are on way to phase out the old style chemotherapy. In case if you have interest in molecular biology, cytogenetics, or immunology, you must consider this aspect seriously at this age only. And at last, the most important point, a lot depends on who is your teacher or mentor. A good teacher will almost always leave an everlasting impression on you and your career. He will teach you to analyze the case, formulate an algorithm, and then come to a logical conclusion at the end instead of creating an academic chaos. Just for the first 20 years of your academic career are exceedingly important. You have to work, and work, get maximum experience. These years will be the foundation of your actual professional life later on. And remember one thing, that there are no shortcuts. So this was the essence of my experience so far, and I hope the young generation will find it useful. Thanks a lot. Thank you very much.
Thank you, sir, for sharing your experience and giving such wonderful words of wisdom that will help the students for their future career. Thank you so much for being with us today as our chief guest. Let me share the screen again. So now is the time to introduce our guest speaker for the day. We have with us no other than Dr. Riya Balikar from Nagpur, and she requires no introduction, but it's my formal duty to introduce her. She is MD, DM, and DNB hematology, consultant hematologist and hemato-oncologist at Blood and Heart Clinic, Kingsway Hospital, Wockhardt Hospital, Nagpur. She is director of Hemo Heart Foundation, ex-honorary assistant professor at Indira Gandhi Medical College, Nagpur. Her core areas of interest include sickle cell disease, ITP, lymphoma, and myeloma. She is a principal investigator in multiple clinical trials. Today, she's going to lecture us on Hodgkin's lymphoma, optimizing treatment in the era of targeted therapy. Well, thank you so much. Over to you, Dr. Riya Balikar.
Thank you for the kind introduction, Amit Khurana sir. And I would like to thank MHG and Professor M.D. Agarwal for giving me this opportunity. So I'll be sharing my screen. So the topic, like Dr. Amit Khurana said, is Hodgkin's lymphoma, optimizing treatment in the era of targeted therapy. This will be discussed under the following headstones: milestones, pathogenesis, staging, risk-adapted therapy, transplant in Hodgkin's. I won't be touching that much because main area of focus is the advances which had happened in radiotherapy, why the need for alternative therapy lines. I'll be presenting that with data, brentuximab and PD-L1 inhibitors, and looking forward, what next in Hodgkin's lymphoma. Hodgkin's lymphoma, as we know, previously called Hodgkin's disease, is a hematological malignancy characterized by the presence of the typical RS cells surrounded by mixtures of non-neoplastic inflammatory cells and fibrosis. Can be classified as classical and NLPHL. For the purpose of today's discussion, we are focusing only on classical Hodgkin's lymphoma. Now, the identification of this disease, little bit into the history. I always like to start with history and some anecdotes from the past. So in 1832, this particular gentleman, Dr. Thomas Hodgkin, who apart from being a doctor was also a philanthropist, and he's done a lot of work as far as abolishing slavery and promoting the locals is concerned. So he, in those days, as we know, diseases were mostly identified post-mortem. So all the physicians, after the patient died, they would go to the morgue, they would dissect the patient, and they would try to find out what was wrong, what went wrong. So he published the data of 7 patients who had similar presentations The title of this article was on morbid appearances of the absorbent glands and the spleen. So this was way back in 1832. And little bit more of history. This is the first drawing of these Sternberg cells, which was published by Dr. Dorothy Reed, who later very unfortunately went on to become a pediatrician. She left her career as a pathologist and she became a pediatrician. And this is the first use of radiotherapy. You can see this child. In 1902, this particular child of Hodgkin's was subjected to localized radiotherapy. And you can see the picture on the right, the lesions have totally disappeared. So Hodgkin's lymphoma was basically a poster boy for radiotherapy. Hodgkin's lymphoma and sarcoma were the two primary cancers, the first cancers in which radiotherapy was tried, tested, and found to be successful. We've come a long way from there. Anecdote again, Dr. Thomas Hodgkin used a concoction of cascarilla, soda, and iodine to treat his patient. Obviously, this could not treat the patient. The patient landed up in the mortuary and as one of his subjects. Then came MOP, the MOP regimen, very well known. Hodgkin's treatment was always MOP. But the problem was with this was they used alkylating agents. The mustard that was used, M stands for nitrogen mustine, which was basically a very bad alkylating agent. And we know that alkylating agents are associated strongly with secondary malignancies. Then came the era of ABVD, 1980s onwards, very rampantly used. And now we've come much, much beyond that. We are in the era of targeted therapy and monoclonal therapy. Now, why am I focusing so much on the basics and the etiopathogenesis? Please look at the diagram of the Hodgkin cell. You can see these cells, though the numbers here are pretty large, but normally the HRS cell constitutes less than 5% of the total tumor bulk, if you see in the microscope. And the basic feature of this cancer is this HRS cell, which is surrounded by a lot of other cells. So basically, we refer to it as a polymorphous cell population. You can see there are macrophages, dendritic cells, neutrophils, lymphocytes, which is CD4+, 8+. And you can see there are fibroblasts, and there are all types of cell which is surrounding this HRS cell. So what is so very different about these cells is what happens is basically this HRS cell is nothing but a germinal center B cell, which has acquired mutations and transformed into this HRS cell. Now, this population of this cell is so much, it's always the concept of survival of the fittest. So obviously, what do we expect? We expect the immunity to destroy this particular cell, but that doesn't happen. And that doesn't happen because of all the chemicals that this cell produces. So it produces a lot of markers which attract these inflammatory cells. And what it does is it makes these inflammatory cells produce chemicals which would help it survive. So basically, we call it evasion of immune surveillance. You can see all these molecules. You can see there is downregulation of Tregs. There is downregulation of the CD4, CD8 cells. There is downregulation of the macrophages. And there is upregulation of all the cancer-promoting genes. Most important gene here to remember is the NF-kappa beta. You can see here T-cell activation, immune escape and checkpoint inhibiting antibodies, resistance to the blockade, and proliferation of the cell. So this is the sequence of events. Now, this is very important when we look at targeted therapy. So this particular model of the Hodgkin lymphoma cells has been called classically the castle and moat model. You can see there is this castle which stands alone and a moat which is normally much bigger than this around the castle, which is just there to protect the castle from invaders. And this is exactly what happens in Hodgkin's lymphoma. Now, that is about the basics. Immunophenotype of Hodgkin's lymphoma, unanimously, all the cells, 100% of Hodgkin's lymphoma would be CD30 positive. So if you have a tumor which is not CD30 positive, it will not be a Hodgkin's lymphoma for all practical purposes. CD15 and is positive in most of the cases, but maybe negative also. So we do see cases of Hodgkin's lymphoma which may be CD15 negative. And PAX5 is again weak positive. So this is the typical immunophenotype of Hodgkin's lymphoma. This is important again from treatment point of view. Before going to the advances and the complicated data, we look at the basics. Approach to a patient with Hodgkin's lymphoma in today's era. What is important again, not just your findings, but your history really matters here. For the duration of the lymphadenopathy, extent of the disease, one thing that really influences our treatment decision, whether this patient is going to receive basic therapy or advanced therapy, would depend on the presence or absence of the B symptoms. B symptoms include fever, drenching night sweats, and significant weight loss. Any patient with B symptoms is classified as having a more aggressive disease than a patient without B symptoms, which is also called A. Comorbid conditions which influence therapy decisions are pregnancy, cardiac, respiratory conditions, and presence or absence of smoking. Performance status, we know we either look at the ECOG or the Karnofsky performance status. Workup, these are investigations which have to be done whenever you're evaluating a patient with Hodgkin's. CBC with ESR. ESR has a lot of prognostic importance here. KFT, uric acid, calcium, LFT with albumin. The viral markers, particularly important for hepatitis B, is the anti-hepatitis B core antibodies. HCV, HIV, pregnancy test, ECO, the LCO is again important. And one thing that we miss in many a times is counseling. Fertility counseling, especially when you're looking at a relapsed refractory patient, or you are planning to put your patient on escalated BIOCOP, really becomes very important. And the psychosocial counseling is again important. We have patients who are, normally psychosocial counseling, Hodgkin's is a good disease for all practical purposes. So treatment duration is short, but in patients in whom the disease comes back again, this counseling really becomes important. PET-CT in Hodgkin's lymphoma, it's the mainstay of imaging for staging as far as Hodgkin's is concerned. So we do a baseline PET. What is a PET2? PET2 is a PET which is done at the end of 2 cycles. PET4 is PET which is done at the end of 4 cycles, and end of treatment PET. So this is the 4 instances in which PET-CT is done in Hodgkin's lymphoma. Role of PET2, which is also called the interim PET, is very important as far as escalating or de-escalating therapy is concerned. We'll see that shortly. So timing is everything. When do you do PET-CT scan? Between chemotherapies, it would be as close to the next cycle as possible. After chemotherapy, it would be 6 to 8 weeks. After radiotherapy completion, it would be 3 months post-radiotherapy. Now, bone marrow, this is a controversial topic. I normally do not do a bone marrow in Hodgkin's lymphoma unless it's absolutely needed. Why? Because bone marrow involvement doesn't have any therapeutic consequences. So when would I do it? If my patient has unexplained cytopenias, barring anemia, anemia is part of the Hodgkin's disease, and this patient has a negative PET, then I want to know what is happening. If the patient has positive PET, what happens here? Bone marrow uptake, which is homogeneous, could be because of cytokine release. As we saw in the pathogenesis of Hodgkin's lymphoma, cytokine release plays a very important role in disease pathogenesis. So a positive PET could be a sign of cytokine release rather than bone marrow involvement. And when is a PET significant for involvement? You don't have to do a bone marrow. If there are multifocal areas, multifocal I mean 3 or 4 skip lesions in the marrow, then you can safely assume that the bone marrow is involved and you don't need to do a bone marrow. Prognosis and staging of the disease. We use the Lugano classification, which is the modified Cotswold classification, Cotswold modification of the Ann Arbor. And this is the topic in itself, so I'm not going into the details. Basically, stage 1 is a single, very important. Even there was a time when I used to get confused during my studies as to what is stage 1 and stage 2. So it is very important to go through the detailed staging system. I don't have time for it here. So stage 1, just in brief, is localized disease with a single lymph node or a single lymph node region. For example, mediastinum, I'm just giving one example, constitutes one single lymph node region. But if the hilar lymph nodes are involved, it becomes two. Hilar lymph nodes are not considered as part of mediastinal region for the purpose of Hodgkin's lymphoma. Stage 1, any localized organ, for example, the spleen, only the spleen being involved without any other lymph nodes, again would become stage 1. Stage 2 is 2 or more lymph node regions on the same side of the diaphragm, or a single extra lymphatic site, like the example, the spleen, along with associated lymph nodes. So spleen with the splenic lymph nodes would become stage 2. Stage 3 is a more diffuse disease, both sides of the diaphragm involved. And stage 4 is a disseminated disease with multiple organ involvements, with or without lymph node involvements. Now, very important is the prognosis. When we say early stage Hodgkin's lymphoma, we are looking at stage 1 and stage 2. So in stage 1 and stage 2, what is favorable, what is not favorable? So we use basically two classification systems. One is the German groups. As we know, in Hodgkin's lymphoma, most of the trials have been done by the German group. So the GHSG, which is the German Hodgkin Study Group, the unfavorable factors, they go slightly aggressive. So the unfavorable factors is more than three nodal sites, extranodal disease. Any extranodal for them becomes unfavorable, including any organ involvement. MMR basically refers to the mediastinal the diameter, which is more than 1/3, maximum mass diameter radius, which should be more than 1/3 of the thoracic diameter. So some people use 10 centimeter as the cutoff, some people use the ratio. So they divide that mass by the thoracic diameter, internal thoracic diameter. So there the 1/3 is the figure that is used. B symptoms, like I said, are very, very important for staging. So any patient without B symptoms with the ESR of more than 50 goes as unfavorable. Any patient with B symptoms, and even if the ESR is 30, goes as unfavorable. And most important to remember here, the most important point is bulky disease. So disease more than 10 centimeters and MMR more than 1/3, either one of the two, classifies as bulky disease. Why this is important, I'll be telling you later. EORTC, which is the European Consortium Group, uses similar factors, but they go slightly less aggressive. So they prefer 4 lymph node sites rather than 1. And extranodal disease doesn't have any separate prognostic significance. So no risk factors becomes favorable. Any one of the risk factors becomes unfavorable. So again, the same thing repeated here. So stage 3B is bad disease, put it as unfavorable. B refers to B symptoms. Now, when we look at advanced stage, the classification system that is used is called the IPS, or the International Prognostic Score. 1 point is given per factor. The points included are the age. Patient-related, we have 3 factors: the age, the gender of the patient, and the stage. So stage 4, age more than 45, male patient is bad disease. And biochemically, we have 4 factors: albumin, hemoglobin, leukocytosis, and lymphocytopenia. These are 4 prognostic factors. So 0 or 1 is low score, 2 to 3 is intermediate, 4 and above is high score. Now, the most important guidelines that we follow as far as Hodgkin's is concerned are the NCCN guidelines. So this is what guidelines are, and then we come to what we are practically doing. So early stage favorable is 1A or 2A, non-bulky, like I said. So 2 cycles of ABVD. ABVD is the treatment of choice here. Here comes the role of interim PET, which is your PET2. Very important to assess response. So if on PET2 you have a good response, if the disease is, see, there are 3 options here. You either continue chemotherapy alone, or you give chemotherapy along with radiotherapy, or you give radiotherapy alone. It depends on what you want to do. Personally, if you ask me what I do, in early stage favorable, I do not use radiotherapy. I do not use it because the disease is not bulky here, and the patient has a favorable risk profile. You're subjecting the patient unnecessarily to a lot of radiation, which was not indicated. But if I have an elderly patient whom I don't wish to give too much chemo, then I would maybe consider radiotherapy in this patient. And the dose of radiation that I use here is not 30, though the rapid trial says 30, I use 20 gray if needed. If the patient has stage 3 here, same treatment again. You would repeat the PET CT maybe and see what happens. And stage 4, don't change treatment. You change treatment only when the score was 5. But stage 4 and 3, I would prefer to repeat the PET at 4 cycles, which is the PET 4. So here I'm not repeating the PET at 4 cycles. I'm doing it directly at end of therapy, whether I choose radiation or no. In PET 4, I'm repeating it at the end of 4 cycles again, just to see how things are. So Duville 5 is when there is florid disease on the PET, I would biopsy it. Positive means the patient is refractory and you change the line of therapy. You treat the patient like refractory disease. Now, the same thing when the patient has unfavorable disease, early but unfavorable, I do a PET 2 here at 2 months and I do additional 2 cycles. See, in today's era, we are looking at personalized therapy. Some years back, it was Hodgkin's lymphoma, irrespective of the stage, you give 6 to 8 cycles of ABBD and you are done. You would give radiotherapy, you do not give radiotherapy. But now what we are looking at is a personalized approach. So there comes the role of escalation and de-escalation. So RATHEL trial, I'll be discussing this in some time, is basically response adapted therapy to Hodgkin's lymphoma. RATHEL stands for that, response adapted therapy. So what they are doing is, they are using PET to guide therapy. So if the patient has favorable response after 2 cycles, you de-escalate the therapy. You are omitting bleomycin, if you can notice from the chemotherapy arm, because bleomycin is the one chemo which has maximum side effects in your ABBD. And if the PET is positive, they are escalating the therapy, escalating it to Biakov, and then accordingly deciding what needs to be done. And one thing which is throughout, which stays constant, is use of radiotherapy. So unfavorable patient with bulky disease, especially patients with bulky disease, have to be given radiotherapy. Favorable patients' dose of radiotherapy, if at all needed, was 20 grade. Here it comes down to 30 grade. Advanced stage, again, you can choose here. You can use ABVD. Certain situations, we do use escalated Biakov. And one thing that I am preferring more and more in these settings is brentuximab vedotin BV plus ABD. Now, this is a category 1 indication for use of brentuximab. So I am using this more and more. We'll come back to this when we discuss our targeted therapy. So same thing, restage, response is good, complete your treatment. If response is not good, escalate it. Still response not good, label as refractory and change your line of treatment. Now, brentuximab vedotin, when you're doing, though we do PET, I sometimes do PET at the end of 2 cycles, but recommendation says you do a PET directly after 6 cycles of brentuximab vedotin with ABD. Escalated Biakov, we don't use it much, but if needed, again, the protocol is this. Now, coming to our proper targeted therapy, immunotherapy, and de-escalation of therapy. We know chemotherapy, why the need to de-escalate? Why the need to use something beyond chemotherapy? We know chemotherapy has a lot of side effects, right from hair loss. We tend to ignore it because we are not at the suffering end. But if you ask patients, especially a young girl who's suffering so much, hair loss, the skin problems, the pigmentation, so many other problems. We know each chemotherapy has sterility again, especially in young girls. It becomes difficult, especially when you're going, using something like a Biakov. Patient's life, the morbidity that is associated with it, apart from the mortality, is too much to handle. What about radiation? We know there is something called acute radiation side effects, the rash that happens, the leukopenia that happens. We know there is pneumonitis which can happen, GI problems like internal bleeding. That will depend on the field that you're encompassing. And the most important long-term side effect of radiotherapy, which is cancers, and breast cancers, blood cancers, and thyroid cancers are typically associated, skin cancers again, with radiation use. So that is why now the need for this personalized medicine where you give your patient only what is needed. You try to balance that small risk of relapse versus that good quality of life that you can give the patient. So that is what I was talking about. The RATHL trial stands for Response Adjusted Therapy for Advanced Hodgkin's Lymphoma. So they've taken advanced Hodgkin lymphomas and early stage unfavorable. They've used ABVD. They've used a PET2 to guide treatment. We've seen this in detail. And in fact, the results are so successful and good that NCCN has actually adapted this in the latest guidelines. PET negative, omit bleomycin. So even in advanced stage, they are omitting bleomycin. PET positive, they are escalating treatment to escalated VIACA. Radiotherapy permitted, you can see here, but not encouraged. And like we have the RATHL trial for advanced and unfavorable disease. In early stage favorable, we have something called the RAPID trial. But problem in the RAPID trial is they are encouraging use of radiotherapy. So I don't personally much agree with that. So you can see the overall survival and the progression-free survival of patients with ABVD and with AVD, you can see it's the same. So adding bleomycin in patients beyond the second cycle who is PET negative has no meaning. You are just subjecting the patient to side effects. And the number of patients that have been enrolled is huge. They've taken 1,200 patients and the follow-up was 87 months, which is something that we cannot ignore. Now, about elderly and frail patients. Elderly frail patients is someone who has a problem with the elderly is the ECOG performance status is poor. They have a lot of comorbidities, predominantly cardiac, respiratory. Mixed cellularity and EBV positive is more associated with the worse outcome, and they're sometimes immunocompromised. So again, I would do a personalized approach here. I would try, guidelines say that you should treat the elderly like you're treating a young patient. So guidelines say you use ABVD. But in a patient who's frail, who has some lung problems, I would prefer to avoid bleomycin in this setting. In a patient who has severe cardiotoxicity, who's got IHD, DCMP, I would prefer to avoid anthracycline. So brentuximab again has been tried in this population. So brentuximab vedotin followed by AVD looks like a good option. Exploring advances in radiotherapy. We know radiation side effects, we've already discussed. Most prominent among that is, I read a paper that said that every 1 gray of radiation that goes to the heart, you are increasing the risk of getting a myocardial infarction by 4 to 7%. And when you look at something like 20 and 30 grays of radiation, you can imagine how high the risk is. So radiation, use it as sparingly as possible, especially in the mediastinum where you have the lungs, you have the breast tissue, you have the heart. You need to protect those organs. And in the abdomen where GI is very sensitive to the effect of radiation. So considering all this, radiation as less as avoided. But then when you talk to your radiotherapy colleagues, what they would say is that radiotherapy has advanced a lot. Initially, what was done was extended field. They had something called a mantle field, which was also called an inverted Y field. That is the radiation. They radiated anything and everything that came in their path. So that was the one which was associated with side effects. After that came the involved field radiation, IFRT, then the involved site radiotherapy, ISRT. And now what we are looking at is involved node RT, NINRT. So that is how much radiotherapy is advanced. So with a minimal margin of healthy tissue, you just irradiated the affected node or the affected site and you are done. So this can really reduce side effects, but I use it only in bulky disease patients, not otherwise. So IMRT is intensity modulated. You change the intensity depending on which organ you're looking at. Volumetric means the volume, the lymph node mass that you're dealing with. Respiratory gating, image guided. These are routinely used. Proton therapy is also used, but it is very much more expensive and doesn't have any added side advantages. Coming to the targeted therapy part. unmet needs. So why the need for targeted therapy? We have ABBD, we have escalated via COP, we have transplant as a salvage therapy. Then why go for targeted therapy? So what are the unmet needs in Hodgkin's lymphoma? So first, let's look at previously untreated, that is de novo stage 3 and stage 4 Hodgkin's lymphomas. Between 40 to 80% of Hodgkin's lymphomas with advanced disease would relapse at some point. And this rate is much higher if you look at patients in developing countries. So you can look at this diagram here. You can see as the stage advances, the 5-year overall survival also reduces. So the 5-year overall survival with best available therapy, here it's 73% in this particular trial, but there are trials which have shown it to be as low as 55 and 60%. Advanced stage Hodgkin's lymphoma have poorer responses to standard therapy than when you look at patients with early stage Hodgkin's lymphoma. So you can see the probability of a freedom-free survival. The graph on the in blue is your stage 1, stage 2 with standard therapy, which is ABBD. Stanford 5 again is something we don't use because of it has alkylating agents. So the graph in blue is the early stage, response is good. The graph in red is the one which advanced stage. You can see the FFS, freedom from disease, is around 65% here. So again, the number of patients who are refractory or relapse, 30%, which is a high number. Now, the thing is, if the patient is refractory or relapse, you would say salvage the patient with chemo again, put the patient on transplant. But it is not as easy as it seems, because you are subjecting the patient to cumulative substantial toxicity, which has so many side effects. We've discussed that. And the quality of life also suffers. One more thing to remember is that transplant, when you're saying salvage and put the patient on transplant, you can see, looking at the long-term effects, you can see the survival post-transplant is as low as 50% post-transplant. So even transplant in this setting is not associated with very good outcomes. So that is why the need for this alternative therapy. So first, we have 2 agents here that we are going to be looking at. First is the immunotherapy. So like we have rituximab in non-Hodgkin's lymphoma, we have brentuximab in Hodgkin's lymphoma. So basically, it's a monoclonal antibody. It's an antibody drug conjugate. So the antibody is the CD30 binding antibody, and the drug that is used here is MMAE, which is monomethyl auristatin A. So that is actually the chemo that is going. So it is a microtubule disrupting agent. So what the drug does is, the conjugate, it takes the drug to the cell, only specifically the CD30 positive cells. You can see the potentiality of these cells to bind to CD30 positive cells is 300 times more than the cells which are antigen negative. And like we discussed, 100% of Hodgkin's lymphoma patients, almost 100%, are CD30 positive. So it would uniformly act against all cases. So the drug takes the antibody takes the drug inside the nucleus, which results in disrupting the microtubules. And this results in cell phase arrest and apoptosis of this cell. And things just don't end here. What happens is, these CD30 carrying vesicles, they come out of the cell and they go and start attacking the other cells. So this one cell, the antibody conjugate that you've given, the molecule would release multiple other molecules inside in small vesicles, and it would sort of cause a chain reaction inside the Hodgkin's lymphoma cell, similar to something you could, correlate it to something like a nuclear explosion reaction. So a chain of events is set. And one thing, even in the immune environment, some of these cells like the macrophages and the lymphocytes also have CD30 positive. So these cells are also targeted. So you're not just targeting the cancer cell, but you're also targeting the microenvironment along with it. So it's an excellent drug. I've used it and I'm really very happy with the results. It's available to us since 2011, and the approvals, you can use it, though these are the trials, these are the approvals, but you can basically use it in any condition, any patient with Hodgkin's. So you can use it upfront in advanced stage Hodgkin's. I wouldn't recommend it in early phase Hodgkin's lymphoma. So advanced stage Hodgkin's in combination with ABD, we'll go to each of the trials in detail. Echelon was the trial which was done. You can use it in patients who are refractory to multiple lines of therapy and who have failed transplant. You can use it as monotherapy, or you can use it along with salvage therapy. And you can also use it in patients as a post-transplant maintenance. So in which patients do I use it? Only in patients who are at a high risk of relapse. Uniformly, I would not put every patient of Hodgkin's post-transplant on maintenance. And the trial to support this is the HRR trial. So frontline advanced stages is our first topic. So this is the Echelon trial. 1334 patients randomized to 2 arms. One is brentuximab with ABD and the other is ABVD with bleomycin. Now, one point to remember here is brentuximab should not be used along with bleomycin because the risk of toxicity increases many folds. And one more thing to remember here is the dose of brentuximab in this setting is 1.2 milligram per kg. Dosing regimen stays the same as ABVD. It is a 14-day cycle. And the number of cycles also stay the same. And endpoint for this trial was the PFS. The other key endpoints were the OS and the side effect profile. And what you can see is there is a very good reduction in the number of deaths, disease progressions in the 2 arms. And if you look at a modified PFS, there is again a difference. But this was at the end of 2 years. I would say this difference is it's there, but it's not very significant. But then look at the prolonged evaluation of these patients. Look at the 6-year data. You can see there is a 32% reduction in the risk of progression in death when you compare the 2 arms. And if you look at overall survival, there is a 41% reduction in the risk of death when you compare with ABVD. So the need for salvage therapy also reduces because as we see the second relapse and third relapse, as the patients relapse more and more, the survival chances also become less and less. So patients need less salvage therapy, patients need less transplants, and side effects are there. The most 2 important side effects with brentuximab that you need to be worried about is neutropenia and peripheral neuropathy. So it is contraindicated in patients with grade 3 and above of neuropathy. And to avoid the neutropenia, we use GCSF. It's recommended, but personally, I don't use it with every patient. I use it in select cases. So these are the side effects. Like I said, neutropenia, neuropathy, abdominal pain. These are the 3 important side effects. Now, summary of this trial. What is most important here to remember is there was no trial till now which showed us overall survival advantage when compared with ABVD. So this is the only molecule, this is the only trial which has shown that a molecule can be superior to your conventional chemotherapy. And a 6-year overall survival advantage is something really to reckon with. So next we look at relapsed and refractory Hodgkin's lymphoma. The standard of therapy in these patients is transplant, obviously. But what about using something to consolidate your response? What post-transplant and using something to help you get a response pre-transplant? So probability of overall survival in patients with post-transplant is around 40 to 50%. Long-term remission, if you look at 5 years, relapse refractory, only 40% of these patients would be alive. We know the different salvage regimens. We use GVD, we use ICE, we use TAP, but we know all these are side effects associated with these regimens, right from marrow suppression, infertility, cardiac side effects, infections, and secondary malignancies. So there is a strong unmet need for effective and safe therapies to treat relapsed refractory Hodgkin's lymphoma. So this is the incidence of relapse in survival in patients who relapse within 1 year of treatment. So you can see these are all patients who have relapsed post 1 year of transplant. Within 1 year of transplant, you can see the survival graph is really, really low. The 5-year overall survival in these patients is as less as 32%. I want you to focus on this. Now, when we look at relapsed refractory Hodgkin's lymphoma, the single most important point that we look at is the time to relapse after the transplant. If it's anything less than 1 year, so if your patient has relapsed within 1 year of transplant, the survival is very, very low, very, very low. You can see the probability of survival at 2 years is 0.98, and more than 12 months, the survival rate is slightly better. So if there was something that could delay this relapse from happening, and that something is not radiation, because radiation again has a lot of side effects. It's not allogenic transplants, but can be brentuximab. So these are again the factors that predict your risk of relapse following transplants. Most important, I said, is the time to transplant. The other factors is bulky disease. It stays the same across different categories. B symptoms, some people have included. Non-response to first-line salvage therapy, and stage at relapse. The higher the stage at relapse, worse the prognosis. So we've again gone through this again. This is the same thing repeating again. Higher the number of risk factors, worse is the survival. So what if, like I said, we can consolidate the response that we've got following transplant with something? And in this setting, we are using brentuximab monotherapy. So we have patients who were heavily pre-treated post-transplant patients who've been put on brentuximab vedotin, and these patients have had a transplant failure. So the total number of cycles that are used in this setting is 16. And dose here, like we saw in the upfront setting, the dose was 1.2 milligrams per kilogram. It was used once every 2 weeks. Here it is once every 3 weeks, and the dose is 1.8 milligrams per kilogram. Number of cycles is 16. There it was 12 doses. Here we are looking at 16 doses. And in this particular setting, you can see the overall response rate. Now, what is important to remember is these patients have even failed transplant. So they've been subjected to a lot of chemotherapy, salvage regimen, they've been subjected to transplant, but still they have relapsed. So you can see the overall response rate in this set of aggressive patients is as high as 75%, and 34% of these patients have achieved a complete remission. So that is really credible data. So again, it is not just at 1 year or 2 years, but if you look at a period of 5 years, 6 years, you can see the OS and the PFS advantage stays. So again, this is the percentage of patients who not had transplant. And again, patients with CR obviously would do better than patients who had a progressive disease or a stable disease at the time of transplant. So again, we know the side effects. Now, this was in patients who have failed multiple lines of therapy, including transplant. Now, the third part is brentuximab vedotin as consolidation therapy in patients who are in remission post-transplant. So this is the trial which showed us that this is the results of transplant. You can see post-transplant also, we know the 5-year survival is around 40 to 50%. So these patients post-transplant, if the transplant was successful, they were put on brentuximab vedotin. So previously it was transplant failed patients. These are patients in whom the transplant has been successful, and the patients have been put on maintenance therapy rather, or you can even call it consolidation therapy with brentuximab vedotin. Again, the dose that is used is 1.8 milligrams per kilogram given once every 3 weeks. We have patients on this and they are doing extremely good. Now, would I put every patient post-transplant in this? The answer is no. I would put only patients who have high risk factors. And which are the high risk factors? Patients at relapse had extranodal disease, patient had B symptoms, bulky disease, patients had a less than CR to salvage therapy. Now, ideally, the patient should have a CR to salvage therapy, but not all patients achieve that. Some patients may not achieve that, but then you still have to transplant those patients. So those patients and patients who had a relapse within 1 year, which is a very aggressive disease basically, or patients who had multiple salvage regimens, these are the patients only that I would put on brentuximab vedotin post-transplant. You can see the side effect profile is pretty favorable, though you're comparing it with placebo, the other arm, nothing was given, but the side effect is very favorable and it is as is seen in normal settings. So as far as my approach to patients with brentuximab is concerned, frontline, aggressive disease, I would use brentuximab along with AVD, 6 cycles. Relapsed refractory patients, I would use it alone or in combination with salvage therapy. Post-transplant, high-risk patients, I would use these patients. I would put these patients on brentuximab, particularly if they have had no exposure to brentuximab previously. And this is about this particular molecule. Now, moving on to the other molecule. This is less frequently used, but again, something to really look forward to in the future. This is the PD-1 inhibitor, the nivolumab and pembrolizumab. Like, very simple to understand here. The Hodgkin cell, you can see the cell here, expresses a ligand, which is the PD-L1 ligand. PD-L1, along with this PD-1 molecule, helps the Hodgkin's lymphoma cell evade the immune surveillance by the T cell. This results in exhaustion of the T cell and proliferation of the cancer. Very simple. So if we can do something to prevent this interaction of PD-1 and PD-L1, we can trigger the microenvironment to attack the cells and destroy the cells. So there'll be no support left for the RS cells. Instead of promoting growth of these RS cells, these cells will actually help the microenvironment destroy the cell. So this is what we're using here, and this is typical immunotherapy. So what these drugs do, they bind to PD-1 and they cause apoptosis of the HRS cells. The drugs which are available for us is nivolumab and pembrolizumab, and they are available for us, not just in Hodgkin's, but multiple other indications as well. So 2015, first successful data with these patients, 23 patients were involved by Stephen Ansel and all. This is the data that was published, and they found excellent results with a good safety profile in patients who had relapsed treatment. Even after brentuximab, the results that were there were as high as 78%. So the complete response was seen in total response, overall response was around 87%, and complete response was seen in around 60% of the patients. So that was about the relapsed refractory settings. We know nivolumab really helps. What about upfront? So this data was published in 2021 by Paula Allen et al. And they studied pembrolizumab followed by AVD. So first the patient received pembrolizumab 3 cycles, and then the patient received AVD. So this is something called sequential therapy in Hodgkin's lymphoma. So what they found was this in advanced stage. So this is upfront use, mind you. Advanced stage and early favorable patients with sequential therapy, you can see at the end of the 3 cycles, the number of patients who got a complete response is 37%, which is extremely high. And at the end of treatment, 100% of the patients had complete response. You can see this is each individual patient, the reduction in bulk which is happening. A similar thing was done by Brockelman et al. This was published recently again. This was nivolumab and AVD. But now here, they've had... they've used concomitant and sequential. Like in the previous one, in the Allen study, what was done was sequential. So first she used pembrolizumab for 3 cycles, then she put the patient in AVD. Here they've used concomitant nivolumab and AVD for 4 cycles, followed by sequential nivolumab, 4 doses. Again, concomitant therapy and this. So there are 2 arms here which they've studied. And what they found was that there was excellent response as far as sequential therapy and concomitant. Both had equivalent response. You can see the two arms. This is concomitant, this is sequential. So both the study results were really excellent if you look at a 12-month and a 36-month period. So looking forward, as far as immunotherapy is concerned, very important is to determine which subset of patients would benefit upfront. In relapsed refractory, we know we have no option. We can definitely use the PD-1 inhibitors. But in patients upfront, which particular subset should you use the targeted therapy and the immune therapy? Maybe the patients with bulky disease, maybe the patients with advanced disease, any biomarkers like chromosome 9p24 amplification is associated with PD1, PDL1 expression along with many other gene expressions, including JAK. And maybe identification of this gene will help us guide us in deciding which patients to use it in. And nivolumab versus brentuximab, right now our experience with brentuximab is huge. Nivolumab and pembrolizumab in Hodgkin's, we don't have that much experience. So which drug to look at? Last, just 2-3 slides and we end. So this is a trial. All these studies that we saw was all in patients above 18 years of age. So this is one particular trial. Checkmate is basically a group of trials where they've studied nivolumab. So Checkmate 744, this trial particularly used nivolumab and brentuximab in high-risk patients with classical Hodgkin's lymphoma, relapsed Hodgkin's, low-risk patients with relapsed Hodgkin's lymphoma. And they avoided transplant in these patients. So because transplant, as you know, the salvage therapy, the transplant per se, there is so much of morbidity and mortality that happens. So if you are offered some other regimen which can bypass it, then why not? So in this set of patients, what they did was, if you can appreciate this slide, they used 2 cycles of nivolumab with brentuximab vedotin. They did a PET to see the response. After that, they again continued the patients on 2 more cycles. So that was PET 2. This was PET 4. So based on PET 2, they didn't change the therapy. And based on PET 4, if the patient had a complete metabolic response, they've shifted the patient, they've continued the patient rather on nivolumab with brentuximab for 2 more cycles, and they've labeled the patient as cured. So these patients have totally received 6 cycles of nivolumab and brentuximab vedotin, and they have been able to avoid transplant. On the other hand, if PET 4 was positive, so anything less than a complete metabolic response, then they've consolidated this with chemotherapy. So they've used brentuximab with bendamustine, and if it was a complete response, well and good, you stay that way. If not, they've transplanted these patients. So now how have they given the chemotherapy, immunotherapy? Nivolumab and brentuximab cannot be given together. So brentuximab is given on day 1 of every cycle, and nivolumab was given on day 8 of every cycle. The dose used was 3 milligrams per kilograms. So low risk and standard risk patients, we're not going into the details of this, but they found really good results across all categories, especially patients with high risk disease. Long-term follow-up. Now this publication, this has just been published in 2023. So long-term follow-up of these patients is yet to come. But if this therapy is showing promising results, so maybe in the future, even we can extrapolate this data to adults, and using a sequential combination of these immunotherapies, maybe we can avoid transplant altogether. So these are the adverse effects that is seen. One important thing to remember with these immune checkpoint inhibitors is the cytokine release which happens and all the ITs, the hepatitis, the nephritis, the pneumonitis, the myocarditis. So name the organ and add itis, all particular organs can be involved. So managing that becomes difficult. CAR-T in Hodgkin's is not as advanced as that in non-Hodgkin's, but we have some drugs which are approved. Novel CAR-T approaches would include CAR-Ts directed against, now currently the CAR-T is directed against the CD30 molecule, which is the Hodgkin cells. So novel molecules maybe can direct the CAR-T against the microenvironmental cells. So maybe you could target the 123, the macrophages, the 19 and the B cells. So this is something in the pipeline. Improving the persistence of CAR-T cells. Now, CAR-T, the Hodgkin's lymphoma cells have this receptor which is called CXCR4. Maybe using cells, CAR-T, which would have this embedded receptor and help the cells to persist in the body longer. Novel targets like the bispecific antibodies and all this is being targeted. So, conclusion. Hodgkin's lymphoma, we've come a long way from the time in 1832. Dr. Thomas Hodgkins used soda and iodine to cure the disease, to the alkylating agents, radiation, and now targeted therapy. Understanding the microenvironment is the key, and escalating or rather de-escalating treatment based on the response is very, very important. So there comes the role of personalized medicine. So the future, complete understanding of this. If we understand the genetics, we understand the immunohistochemistry and the etiopathogenesis, maybe we can have better drugs. Chromosome 9q amplification is a good target. Anti-CD30 PD-1 inhibitors. I think the cost, if it comes down, it is something really to look forward to. Novel CAR-T therapies. And like in CML, we are looking at a close to 95 to 100% cure rate. Would Hodgkin's lymphoma be the first aggressive lymphoma to have a 100% cure rate? That needs to be checked. Thank you very much.
Thank you, Dr. Riya Balikar, for that wonderful overview from bench to bedside of the entire Hodgkin's lymphoma. You covered almost everything, including the novel targeted therapies. Thank you so much for that wonderful lecture. And now I request all our discussants to please put the raising sign so that we can start our question answer session with Dr. Riya Balikar. Yes, the first one we have is Dr. Javed Rasool. Your question, please. Sir, you're muted, sir. Dr. Riya, please, can you stop sharing? Yeah, okay.
Yeah, stop.
Sir, please, you are muted, sir. Please unmute yourself.
Okay, sir. Audible now?
Yes, sir. Please go ahead.
Thank you, Dr. Riya, for such a brilliant, wonderful lecture. It reminded me of APML, when in 1980s, the median survival was just 10 days because people will treat with VCR and steroids, like they are treating ALL. So same way you started your Hodgkin's lymphoma, the time when there was soda being used in 1932s, and now today the going toward the last heading was future. Maybe we look in the cart in the future. So I have just few queries. One is that you yourself said that BCOF you are using as upfront in very few number of patients. So how do you choose between?
What is the question, sir?
My question is that the front line, BCOF you said you are using in very few patients. Who are those subset of patients where you give upfront BCOF? Seeing the modern, the ABVD or AVD has picked up as the front line. So that's my question.
Yeah, so honestly, it's been a long time that I've used escalated BCOF. I more prefer ABVD or brentuximab with AVD as initial therapy for advanced disease or early disease, vice versa. Escalated BCOF, one particular subset would be, sir, in patients in whom the disease is really aggressive, but option of brentuximab is not available because of cost issues. The patient is young, the patient has bulky disease. In this particular subset, maybe you can use escalated BCOF. One go would be if after doing a PET-2 in your stage 3, stage 4, and the early stage unfavorable patients, if you've still not got the response that you wish to get, so after PET-2, maybe the response is still, you're looking at a Duville 4 or 5, and the patient is not willing for a brentuximab-based therapy, then in this particular set of patients only, I would give them the option of escalated BCOF. Because of the toxicity and everything, we would prefer to avoid it as much as possible.
Yeah. Okay, thank you. Nice answer. Good.
Thank you, sir.
Thank you.
Thank you, sir. Dr. Rajan Yadav, your question, please.
Thanks for the talk, ma'am. Apologies, I have poor signal, so my video is not working. How do you treat anxious to conceive patients? I recently came across a patient who was 20 years of age, 1 month into marriage, and we sent her for oocyte preservation. The issue was that her oocytes were not fully developed after 1 month of those hormones, and she had developed symptoms because of a mediastinal node. So, what should we have done in that? And the second question is, where do you place RT in salvage therapy? Thank you so much.
Yeah, thank you so much for your questions. Now, coming to your first question, this girl is young, and was it an early stage disease or was it an advanced disease that we are looking at?
She was at least stage 2.
Stage 2 disease. So stage 2, you can safely use ABBD. And there is a lot of data now that suggests that using ABBD does not much affect the fertility options. There are some isolated case reports where yes, but in those patients, more of radiotherapy was used, most of the alkylating agents was used. So post ABBD, I would say around 80 to 90% of the patients do conceive. Regarding the see, if the patient, in case of a male, semen collection, or in case of a lady, oocyte retrieval, if you can do it, well and good, you can bank it and keep it for further use. But like in this lady, it was not possible to do it. And we cannot delay therapy much, because if you delay it, the stage 2 would become advanced stage, and then the patient would not be responsive to therapy that much. So I would suggest we go ahead with the ABBD. I wouldn't use anything beyond ABBD in her. And after that, she has time, she's young. And specifically in this lady, I would not use radiotherapy, because it would affect her fertility and maybe even increase her chances of getting breast cancer. Regarding the second question, radiotherapy, I'm not a big fan of radiotherapy, but in your salvage setting, so if you have given salvage therapy and the patient has got a small focal lesion post your salvage therapy and you wish to go ahead with a transplant, only in that case, I would give radiotherapy to that particular local region and then to take the patient up for transplant.
Thank you so much, ma'am.
Yeah.
Thank you, Dr. Rajan Yadav. Dr. Gopinathan, your question, please.
Good morning, ma'am. Thanks for the wonderful talk. Actually, it was a pretty concise talk. My question is regarding the post-salvage chemotherapy, particularly when using immune checkpoint inhibitors like nivolumab in combination with TICE as salvage therapy for Hodgkin's lymphoma. What is the incidence of autoimmune complications you do see with approximately 2 cycles of nivo-ICE? And particularly post-autologous transplant? That is the first question. And second question is, right now I have a patient who has been post 2 cycles of nivo-ICE and then autologous transplant. And now he has developed, during the engraftment, he had some engraftment fever, and which kind of literally prolonged for quite some time. And now he had landed up with some kind of inflammatory arthritis. So how would we need to approach in such scenario?
Yeah, coming to your second question first, the post nivo and post transplant, the fever that you get, most of the times it is steroid responsive. So normal settings, you would hesitate to give steroids in these patients. But in this particular setting, if the patient has inflammatory arthritis and there is a fever, it is because of the nivo that you've used, the inflammatory response, the CRS that you've got post the nivo. And this is particularly seen post transplant. So I would put this patient on low dose of steroids for as short duration as I can, maybe 1 to 2 mg per kg, as low dose as possible, as short time as possible, and then taper it rapidly. Regarding the second question, use of nivo and autoimmune phenomenon, we see a lot of it, but we see it more in young patients. We see it more in patients who had some autoimmune disease previously. Routinely, rather than a frank autoimmune phenomenon, we see more of the inflammatory phenomenon. We see more of the nephritis, hepatitis, arthritis which happens, and it is easily treatable with steroids. But if this persists beyond a particular period, like you are not able to cut down on your dose of steroids for a period of 12 weeks, then I think you would not be able to use nivolumab in the future for this particular patient.
True, ma'am. True.
Any other question, Dr. Gopinathan?
Yeah, that's it, sir. I used steroids for this patient. The same way as you told, ma'am. I had used steroids for this patient almost when I was using it for almost 4 weeks. 4 weeks when I tapered down slowly, again the symptoms started recurring. So I mean, time has to tell the answer now. I think over next 2 weeks, maybe I have to follow his course, and then maybe I'll be able to get a better image.
So you're still using Nivo in this patient, or you've stopped using it completely?
No, ma'am. No. He's 2 months into post-transplant. I have not started using Nivo.
Still
Like
he has
he's
the
still on
fever.
this. Yeah, still on
Yeah, that's a
steroids. But
problem
now,
with Nivo. Yeah.
symptoms have abated. Joint pains, fever, these things have abated now. Now I have to just follow. Maybe I have to change the maintenance to a BV-based maintenance or something.
Yes.
I cannot use
Then
Nivo.
would be a better option. Yes. Thank you.
Thank you, ma'am.
Thank you, Dr. Gopinathan. Dr. Akansha Garg, your question, please.
Yeah, hi, Dr. Ria. Nice talk.
Thank you.
I just wanted to know your experience with the use of brentuximab vedotin, and if you've used it, then what side effect profiles have you seen in your cases?
Yeah. So I've used it basically in all three settings till now. I've used it in pediatric patients also. I have a 16-year-old girl who had stage 4 disease, and I've used brentuximab as frontline therapy in combination with AVD. So this particular patient, the side effects that I faced was, she had presented with a very high count. Her count on presentation was 45,000.
Yeah.
So I did not give her GCSF in the first chemo, but from the second and third chemo onwards, she had neutropenia. So neutropenia is something I have seen, not in the first cycle, but in the second and third, she did have it. And one more thing that she had, and it was peripheral neuropathy. But it was really, it was a grade 1 peripheral neuropathy, and it settled just with using Neurobion. So I could safely continue brentuximab in her. Other problems that we face routinely are the normal, sometimes some allergic reaction, some abdominal pain, that is routine. Post-transplant setting also I've used it in a patient who was refractory to 2 lines of therapy. Then he was transplanted, and it was with Bren with ice, the salvage regimen, then transplant, and now he's on maintenance brentuximab. He's doing pretty good, but there are some neutropenia episodes and some episodes of infections, even with GCSF prophylaxis in that patient. And there's one more patient in whom I'm using it, but this particular patient is doing good, and GCSF prophylaxis, though recommended, I'm not using in this particular patient.
Okay,
but,
and
yes, please.
Yeah. And in patients who have low ejection fractions and newly diagnosed Hodgkin, so what is your go-to treatment protocol for these patients?
Yeah.
If they have like 20-25% EF.
Yeah. So I would, if the patient is affording, then see, the thing to do here obviously is omit the anthracycline. So if the patient is affording, then I would counsel them for a brentuximab based regimen where I would avoid the anthracycline, avoid the bleomycin. So just I have 2 drugs. I have vinblastine, I have dacarbazine, and I would prefer adding steroids to this with the brentuximab. Now, if that is not an option, EF is around 40-45, then I would still try giving the liposomal formulation of the doxorubicin that is available to us and that is safe. Now, one more thing that is there, I have not tried using it, but there is a particular antidote for this anthracycline-induced chemotherapy. I think that's called dextrazosone or something. So that is available in India. So maybe using that and using this. But as far as possible, avoid anthracyclines in this patient and counsel the patient for brentuximab. Brentuximab is pretty safe in patients with low EF.
And I have one more question. Actually, patients with the advanced Hodgkin, and they have a very high IPS score. So in those patients, like once your interim PET, if it is showing a dual score of 3, it's not 4, 5, not 1, 2, but 3. So do you continue with the ABVD or the AVD, or do you escalate either to be a COP or something like that? I mean, do you consider 3 as a optimal response? Because that is sometimes I've seen these patients relapsing later on, and they usually have early relapses.
Yeah. So it's honestly a gray zone. If you go back to the NCCN guidelines, in the early stage, they classify 3 separately. They put 1, 2 together, they put 4, 5 together, but 3 is separate for the same reason that you said. So So you try to escalate your response because anyways you are giving suboptimal therapy. But there the escalation of response is by giving additional cycles of ABBD. So instead of giving total 4, they give 6 cycles of ABBD and they repeat a PET at 4 cycles. That is the PET 4.
But I'm talking about the advanced,
Advanced
the stage 4
stages,
here.
yeah, advanced stages NCCN classifies 3 along with 4 and 5. So
Okay.
it classifies 3 along with 1 and 2. I'm sorry.
Yeah, so the 1 to 3 is.
Yes,
yeah.
1 to 3 is clubbed together. But personally, if you ask me, do we love 3, I would escalate therapy. If I'm giving ABBD, I would put the patient on Viacop or maybe, try to add brentuximab at this stage.
Okay.
But NCCN doesn't recommend that.
Yeah. Thanks.
Thank you.
Thank you, Dr. Akansha Garg. Dr. Dilip Gohkar, sir, your question, please.
That was excellent presentation, Riya.
Thank you, sir.
Very informative, simplified slides, and quite a good revision. I just have one issue with these patients. Quite a number of patients with Hodgkin's disease, initially we were giving them extensive radiation, extensive chemotherapy, lot of bleomycin and whatnot. But a few did become infertile. How do you manage this patient? I mean, how do you do with preservation of ovum or this thing? And what is your own personal experience with this patient? Has it succeeded after preservation of ovum or something like that? And where these facilities are available currently?
Sir, we have semen harvesting facilities. We have it in Nagpur also. But oocyte stimulation is something, and preservation, we don't have oocyte banks here in Nagpur, but in Bombay and in the major metros, they have it. So they are doing it routinely. So the best thing would be to prevent this thing from happening would be by harvesting. Obviously, that's not an option in children, but young adults who are planning to have a family, oocyte harvesting and semen harvesting, semen banking is a very good option. Then you can encourage them for IVF later after completion of the therapy. Now, with standard therapies, like I mentioned, ABBD is not a risk factor for causing infertility anymore. It is safe. But so in young patients, as far as possible, I would prefer to avoid radiotherapy. I would prefer to avoid use of regimens like Viacop, which would induce infertility.
Thank you.
Thank you, sir. Dr. Nima Thanda, your question, please. You're muted. Kindly unmute yourself.
Yes. Thank you for your very comprehensive lecture, Dr. Balika. You have already answered most of my questions, but I have a few questions left. One is, how do you consider to choose consolidated therapy, consolidated agent in relapse refractory in post ASCT setting? I mean, do you choose brentuximab or nivolumab? And we have learned, and the second question is that we have learned that we should also not only to the tumor cell, but also to the microenvironment in Hodgkin disease. So do you have experience using rituximab in Hodgkin treatment? And I'd like to learn from you that your experience regarding response and treatment of nodular lymphocyte predominant Hodgkin lymphoma.
Okay. So the first question, I think it was the brentuximab and nivolumab, which drug to choose. So nivolumab is associated with a lot of inflammatory reactions, inflammatory responses. So personally, if you ask me, I would prefer brentuximab. I've used it. I'm very happy with the drug. But in patients in whom, as part of induction therapy, you use brentuximab, then you have to use nivolumab or pembrolizumab. So in patients who are exposed to brentuximab before, you would prefer using nivolumab or pembrolizumab. Otherwise, my drug of choice is brentuximab. That was the first question. Second question is, I think rituximab in Hodgkin's lymphoma.
Yes.
Rituximab is used in NLPHL, the nodular lymphocyte predominant Hodgkin's lymphoma. So you want the treatment regimen of that?
Yes, I'd like to learn from you. Yes.
Yes. So we basically stratify stage 1, stage 2, stage 3, stage 4. In a patient with limited disease, you can just do plain radiotherapy and the disease would be fine. Sometimes a simple excision biopsy also would be good enough. And maybe you can consider adding rituximab to this patient. But all other patients, the treatment of choice would be R-CHOP-based therapy. Rituximab along with CHOP. NLPHL is a good disease. It's, I would say, better than the other lymphomas with excellent cure rates, as good as 80 to 100%. So R-CHOP would be the backbone of therapy in NLPHL, unless it is a very localized disease, which would just respond to plain radiation or maybe just that lymph node biopsy that you've done. I think I've answered this.
Yes. I like and I like to know that if nodular NHL is relapse, what will you do in the relapse case? In the relapse nodular lymphocyte predominant, so what is your treatment protocol?
Relapse would depend on whether it was early relapse or a late relapse. Patients with a late relapse, maybe relapsing after 3 years or so, I would try to use the same therapy again. But early relapse, I would use some consolidation therapy and maybe take the patient for a transplant. One more option in this patient is Gazyva, which is the other anti-CD20 molecule, which can help in patients who have been exposed to rituximab and not, they've not done well enough with rituximab. So DAR-EPOCH, where you, instead of rituximab, that is the dose-adjusted EPOCH, combining that with Gazyva may help in this setting. And even if that doesn't help, then salvage therapy with autologous transplant rescue would be the option.
Thank you very much.
Thank you.
Thank you, Dr. Thanda. Dr. Nitin Gupta, your question, please.
So, hello, am I audible?
Yes, sir.
So thank you, Ria, and excellent talk. And you have covered it in detail, but again, it is a very challenging topic, and I believe it is coming more challenging with the time, with the availability of the newer therapies now. So how to use them in the front line and relapse setting. So two things, maybe your opinion or maybe based upon the data you have. So how to choose brentuximab vedotin in the frontline therapy in our practice, and at the time of relapse, what should be our salvage protocol in the patients who are transplant candidate?
Right. So brentuximab upfront, I would use in high-risk patients like stage 3, stage 4. If the patient is affording, the patient has bulky disease, unfavorable factors, IPS score is high. Anyone with the IPS score of 4 to 7 and stage 3, stage 4 disease, with the bulky disease, with these symptoms, this would be my ideal candidate for brentuximab vedotin, and I would combine it with ABD in the upfront setting. Coming to your second question, so salvage therapy. Salvage therapy again would depend on which relapse it is and what drugs you've used previously. So if you had a relapse with ABD, then my salvage therapy of choice would be ICE. I would really not add brentuximab or nivolumab upfront unless the patient had an early relapse. So if the patient has relapsed within 12 months of start of therapy, or if the patient has aggressive disease as relapse, so patient has a stage 3 or stage 4 disease, bulky disease, and patient has had an early relapse, in this case, I would add brentuximab with ICE would be my go-to regimen, or maybe pembrolizumab with DAB or nivolumab with ICE again. These are the salvage regimens we can look at and then take the patient for transplant.
So does it impact the stem cell mobilization, adding rituximab or toxicity of the beam conditioning if you use?
No, sir, because we've had 3 patients till now who've undergone, one of them, I think all of them had brentuximab. Nivolumab was used later in the post-transplant setting in one. So none of them had any problems as far as the cell mobilization was concerned. We used plerixafor in one, but that was because it was a heavily pre-treated patient. So we've not experienced any problems with brentuximab. Nivolumab in the pre-transplant setting, I have no experience, but I've used it post-transplant.
Right. So nivolumab, we have good experience compared to the brentuximab. So some of patients are doing well off on nivolumab and they are in disease-free post relapse post autologous also. So it's working well. So one last query, if we have time. Um, so somebody who relapses many years after frontline therapy like ABVD, so maybe 7-8 years after, how do you treat that? Do you do
Yeah.
transplant or no transplant, and same protocol or different protocol?
I would use the same protocol, sir. 7 to 8 years post-transplant, I would first see this biopsy confirmation, whether it is Hodgkin's or we are dealing with some other malignancy. Because NHL post-Hodgkin's is known to happen,
I know it
particularly.
is a gray zone because it is difficult what to
Yeah.
use. They had, so of course it is a same disease
Yes.
at the time of relapse, and they had a very good so say clinical scenario maybe we come across very rarely, I believe. So I had a patient recently who had relapsed maybe 7-8 years after initial ABVD. So I was thinking, does she really need a transplant, or does she will be okay with I do use GDP protocol as a relapse, but of course
Yeah, I would personally treat her as the new case, fresh case. I would risk stratify her again. If the disease looks aggressive, stage 3, stage 4, then maybe use more aggressive therapy. But transplant in this particular patient in the frontline setting, I would avoid, sir. I would maybe even use just ABVD here.
I'm thinking the same. Thank you very much.
Thank you, sir.
Thank you, Dr. Nitin Gupta. Dr. Aryan, your question, please.
Hello, Dr. Ria. Thank you for your lecture. So, two questions. One, your approach in the management of Hodgkin lymphoma patients who have advanced liver dysfunction. Sometimes it is because of kind of the vanishing bile duct syndrome, which they have, or sometimes it is an infiltration. And so what is the safe regimen? Like what do you use, a platinum-based regimen or a COP, or you would like to use a targeted one? I mean, or any experience you have had in managing these cases?
See, we first need to see whether this, are we looking at disease-related hepatic dysfunction, or the hepatic dysfunction is because of some other condition. For example, you're looking at a CLD with alcoholic liver disease. I would prefer to go really slow in this patient. But if there is a patient with liver involvement, and the best imaging tool that will help you here is an MRI. Rather than the PET-CT, PET-CT would not show you that florid liver involvement because of naturally there is some PET uptake which happens in the liver. So I would first do an MRI to see what we are exactly looking at. Again, obviously with your doctor and everything. So if it is because of disease infiltration, then I would personally prefer to use full dose of the therapy. I would do that. And I would add steroids also to this regimen as far as possible, just as a safekeeping. But if this patient has CLD and that is causing it, then obviously all your hepatotoxic drugs, right from your anthracycline and your vinblastine, dacarbazine, the doses would have to be reduced depending on how much bilirubin you're looking at, how much elevation in your liver enzymes you're looking at. Now, if you're looking at your brentuximab and nivolumab, there is no dose adjustment for nivolumab. So irrespective of the bilirubin and your enzymes, you can safely use nivolumab and as it is, the same dose. The dose here is 3 mg per kg is what we are looking at. But in case of brentuximab, and you have a CLD, chronic liver disease, the Child-Pugh score mild to moderate, then you would prefer to reduce the dose of brentuximab from, suppose you're looking upfront, from 1.2 mg per kg, that is the dose that you're using, you would cut it down to 0.8 mg per kg. But if you're looking at a severe Child-Pugh impairment, then I would omit the drug altogether. But nivolumab, irrespective of your renal and liver impairment, is completely safe.
Yeah. So at least, so sometimes, so because the dose labeling does not mention that whether that, so for the routine drugs, the anthracyclines or the vincristine, they don't mention whether it is because of the lymphoma per se, or whether it is.
So I think some MRI, see if your ALK phos is increased, you know, there are
that we can assess that
So it's difficult, I understand, but maybe doing a proper MRI or Doppler can guide you as to whether this is chronic liver disease or whether this is, because if it's because of the disease, then if you give suboptimal therapy somewhere along the line, you are actually prolonging the disease. Right? So I would prefer to hit it hard and observe the patient.
Yeah. And one more question. So, so if it is a relapsed Hodgkin, maybe particularly when, so even we use as a, if it is a relapse after 1 or 2 years, we tend to use a chemotherapy per se because of the finances, say a GDP or a ICE-based salvage protocol. But if it is a third line relapse and you are looking at a auto transplant finally, so would you, how do you choose between a BV-based regimen or a Nivo-based regimen? Because Nivo sometimes is more cost effective, and then there is data to say that it kind of sensitizes to the chemo beam which we would ultimately be giving. So, but from what I could gather from the previous discussion is that you probably tend to use BV higher up. So any particular rationale for that?
It depends on what you are comfortable with. I've been using brentuximab and very happy with it. We use nivolumab, but there were a lot of side effects in the patient's immune related, so we prefer to skip it. But like you said, the data, and I've myself shown the data. If you look at the Nivo data pre-transplant, nivolumab along with some salvage therapy, the CR rates are as high as 60% and the overall response rate is as high as 85%. So if you ask me, Nivo pre-transplant, particularly instead of Bren, I would prefer it. I would not prefer it. It is better. But if you look at my experience and the drugs that I have used, I'm more confident using brentuximab because I've got equivalent results with that. But now this particular patient has relapsed post 2 cycles, post 3 cycles. So in this patient, you want to really go aggressive. So in this particular patient, I think Nivo plus whatever salvage therapy that you want would be, I think, ideal rather than using brentuximab.
Thank you.
Thank you, Dr. Arinjin. One similar question from Dr. Yimon Tent. She has a case of Hodgkin's lymphoma, unfavorable, post-chemo 6 cycles of ABVD. There was a residual mass, and so it was then followed by 6 cycles of BV. Still, there is residual 3 centimeter mass of iliac nodes. PET dual score is 4. So how would you proceed further now? Whether you will continue with BV or would you use nivolumab or any other therapy?
Firstly, I would biopsy this lymph node because I think it's in the iliac, inguinal or iliac, was it?
Iliac lymph nodes.
Inguinal?
Iliac
lymph nodes. So as far as possible, I would try to biopsy this lesion because sometimes, you know, PET can give you a false positive response. So always in such settings, when there is a dilemma, biopsy it. And see if your patient is affording and willing, then maybe you can think of switching therapies. But sometimes something which helps, a 3 centimeter mass is a little too big. But if it was a little smaller, maybe radiotherapy localized, but iliac again, I don't know how far. If your radiotherapist is really good, maybe abdominal shielding and everything, and if you can use a BMAT, then you can consider plain radiotherapy itself and continue your brentuximab. Or if your patient is affording, then maybe switch this patient to nivolumab. And as early as you can, you maybe transplant this patient. For a transplant, you don't need a complete response, though that is the ideal situation. Anything less than a CR would also do. So maybe transplant this patient and then put this patient on nivolumab maintenance therapy because brentuximab is not really helping here. So you could do a 2-weekly nivolumab or a 6-weekly pembrolizumab, depending on whatever is okay with you. Nivo would, I think, be more cost effective for a period of maybe 24 doses or so.
That was an excellent answer. So any other discussion has any question for Dr. Ria? There are no more questions in the chat box. Yes, Dr. Pujita Reddy, your question, please.
Good afternoon, ma'am. Thank you for that excellent talk. I have 2 doubts, ma'am. One is regarding on the same lines regarding the oocyte preservation. I had a patient recently and married 3 months into the marriage. She was diagnosed with stage 4 Hodgkin's lymphoma. So I gave her an option of oocyte preservation, but with we told her counselor that the disease is really high risk now. We have to go to the therapy as soon as possible.
Yes.
She went to the reproductive specialist, and there she has advised we can go with the, instead of oocyte preservation, which takes 1 to 2 months of time, we can go for the ovarian tissue cryopreservation. So do you have any experience on this aspect, like ovarian tissue cryopreservation, but the patient eventually didn't opt for that option? So I just wanted to know whether you have advised this option for any of your patients.
No, honestly, no. I have no experience with ovarian tissue cryopreservation. And honestly, I don't know how much it helps, because I discussed it with one of my colleagues who stays abroad India. I don't even know which centers are doing it. But what I was told is that there is lesser success rate than oocyte retrieval. Oocyte retrieval is something that is much more feasible, but it takes time. Agreed, in stage 4 disease, you cannot wait. But I myself have never gone ahead with this.
Sure, ma'am. Thank you. And the next thing is, what general infection prophylaxis you routinely give for your patients? Is
So
there
in
anything, or
patients with
what is the
ABVD,
incidence of viral reactivations you are seeing in your ABVD treated patients?
yeah, in ABVD, I routinely give Acivir and Septran both as prophylaxis. I do not use antifungal prophylaxis. So breakthrough virus that, and I give it for the period of the therapy, and then for 6 months post therapy. So breakthrough herpes, I have never seen in Hodgkin's till now. I've seen it in patients with APMLs. I've seen it in myelomas, but in Hodgkin's, if you ask me, I've never seen a patient who's come with a breakthrough herpes till date.
Thank you.
So in the same context, what all prophylaxis are you giving for BV therapy? BV plus
Brentuximab? Yeah.
Yeah.
You're combining it with AVD. So
Yes.
I give Septran and I give Acivir both as prophylaxis. No routine fluconazole or levoflox. But in patients, like one of my patients had recurrent post-transplant setting, she had recurrent infections because of neutropenia. So I did give a short course of prophylactic levofloxacin, 250 milligrams for a short period of time, and then stopped it.
Thank you. Dr. Javed, sir, your question, please.
So you are muted, sir.
Please unmute yourself, sir.
Yeah. Dr. Ria, do you have any experience of pediatric population being treated with OEPA, AVPC, like those sort of things? Do you have sort of that experience, or how do you recommend them in the present era? Do you recommend them?
Yeah, so pediatric, the treatment is different than adults. Up to a child up to 12 years of age, you would prefer to go as safe as possible. You would prefer to avoid alkylating therapies. So I do more of adults, but I can tell you this, that in low and intermediate risk. So like we have unfavorable early and late, they have low, intermediate and high risk cases. So in low and intermediate, the treatment of choice first line is A, B, V, E. E is etoposide. They don't use dacarbazine, and as much as possible, they avoid vinblastine. They use vincristine. And in late cases, high risk cases, a child as young as 2 years of old can be given brentuximab. In high risk patients, in children particularly, the regimen of choice is brentuximab along with AVETC, which is your anthracycline, vincristine, etoposide, and prednisolone and cyclophosphamide. That is the drug of choice. But I don't see pediatrics. I see more than 12 years, sir.
Okay. Thank you so much.
Thank you, sir. Dr. Aryanjan, you have another question? Dr. Aryant? Okay, so that has been stopped. Okay, there is a question related to elderly Hodgkin's lymphoma. What salvage protocol would you use with combination of BV?
Salvage therapy.
Salvage therapy, elderly Hodgkin's lymphoma.
Firstly, you want to see if this patient is fit for your transplant or no. I would preferably avoid.
The question is about 75 years male. He's coming with a residual Hodgkin's lymphoma post ABVD. So what salvage protocol would you use now?
I would not transplant this patient, but the therapy that I would use here would be brentuximab is good enough. So maybe brentuximab and GDP would be safe in this population. Maybe 2 to 3 cycles of this, repeat a PET CT scan, and then continue this patient on brentuximab. for a total of, if it permits, then 16 cycles. Transplant is out of question here, I feel, especially in India.
Any of your experience regarding BV plus decarbazine in elderly patients?
No, but BV with bendamustine could be an option. You can go for a bendamustine 90 mg per meters. I know there is data as salvage therapy, BV with dacarbazine, there are some studies. But I would personally prefer BV with bendamustine, 90 mg per meter square, 2 days.
And there was an MD Anderson data regarding Briacad. It came this year. So any experience, have you used any time for elderly Hodgkin's?
No, never used BV with dacarbazine, not till date.
Briacad, no. So anybody else? Fine. So there are no more raising signs, and I have finished all the questions from the audience. Well, thank you so much, Dr. Riya Barikar, for that wonderful lecture. You covered almost everything in Hodgkin's lymphoma. That was really great. Wonderful question answer session. And I now hand over
Thank
to
you so much.
Zydus for the final
Thank
vote
you
of
so
thanks.
much.
Mr. Sumit Madan, the screen is yours.
Thank you, Dr. Riya, for sparing your valuable time. And it was a wonderfully crafted, very lucid presentation. And we have many key takeaways from this wonderful presentation. In fact, you have given a 360-degree view of managing Hodgkin's lymphoma with respect to all targeted therapies available at present. On behalf of Zydus, I thank Mumbai Hematology Group, Dr. M.B. Agarwal sir, for providing us this wonderful opportunity and making us a part of this esteemed academic discussion. I also thank our chief guest for the day, Dr. Dilip Gohkar, all the discussants and participants who have joined us for this webinar. Special thanks to Dr. Amit Khurana for navigating this entire webinar in a highly proficient manner. Last but not the least, this series of webinar is possible only because of continuous support from Perfect Square team. So thank you so much, everybody. Have a wonderful Sunday.
Bye. See you next Saturday, Sunday, 7 p.m. Saturday, 11:30 a.m. Sunday. Thank you. Bye-bye.
Thank you. Bye-bye.